Hello everyone, we are from Group 2 and our ICF product was done on Benny Pearl.
Here are our objectives. So we want you to be able to understand the important patient history, psychosocial aspects, prognostic factors, the role of the whole healthcare team, important exam components and outcome measures, the K-level and prosthetic components, ICF parts of this case, then the patient prognosis and interventions and discharge for this case.
Okay, so here's some background information on Benny Pearl. He is a 60-year-old African-American male who weighs 220 pounds and he is 5'10". He is currently working as an owner/operator of a gas service station, and one of his goals is to return to work. He says he actually needs to return to work. He is married to a woman who is a part-time RN. He recently underwent a right transtibial amputation. His anticipated length of stay was 1 week, transition to home health and outpatient rehab. He smokes about 2 packs a day, and when he came in, his O2 stats were about 94%. You can see his current medications are Procardia, Coumadin, Capitan, Darvocet, and Lasix. His home environment is he lives on the outskirts of town in a very small house, which could end up being an issue down the road. He lives with his spouse. His 3 children are currently not in the same part of the country, so they can't really help him out too much with his daily activities. When he came in, okay, so here's a little bit more of the critical history of Benny Pearl. He came in for a primary medical diagnosis of a right transtibial amputation, which was secondary to a failed femoral popliteal bypass, which was secondary to wound infection. He had an equal flap procedure, which was closed with 18 sutures, and this occurred approximately 14 days ago, and the result was a pretty short residual limb. Another kind of concern is that the ABI on the unaffected limb was about 0.8. He also has a history of smoking, and like we said before, he has previously been diagnosed with COPD and CAD, and his BMI is 31.6.
Psychosocial issues that may affect Benny's care. Although he will have visitors, he will be temporarily isolated in the inpatient rehab facility. He will also have long-term isolation. He lives with his wife, but his 3 children are all grown and live in other areas of the country. He shows signs of depression and confusion. Depression alone can make it difficult for a patient to accept and deal with the loss of limb, but adding in the aspect of confusion could increase the complexity of the emotional and psychological issues of the patient. Mr. Pearl will have to be educated on the realistic expectations for his level of functioning after the amputation, and he will have to accept that he might not be able to do everything that he used to. Depression is common in individuals that earn a living with a job that has a lot of physical requirements to complete the job. Pressure to return to work due to financial obligations, body image issues, sexual functioning concerns, and phantom limb pain could contribute to depression and or confusion. Therefore, these possible issues will need to be monitored and addressed if they arise. As we all know, Benny will go through the 5 stages of grief over the loss of his limb and changes in his life. These include denial, anger, bargaining, depression, acceptance, and hope. He will need to be monitored closely for signs of complicated grief. Benny will also lose independence. Mr. Pearl owns a gas station and operates it, and there are probably aspects of this job that he can no longer perform on his own. That is a difficult realization for a recent amputee to face. Mr. Pearl may also experience financial hardship from being out of work and feel depressed for not being self-sufficient or able to provide for his wife. With the financial hardship, as I've discussed, he is out of work, and he may need help from his children or his wife to get a job to cover the expenses while he recovers. Hopefully the patient will be able to recover fully and return to work at the gas station by the end of therapy.
So this slide is just going to examine some of the positive and negative prognostic factors for our patient. The positives include the fact that he has a spouse who is a registered nurse part-time, so she can help in rehab and performance of ADLs. She can help care for residual limb and increases home exercise program adherence. The patient is motivated to return to work, so that's going to be big for him. And he also has good insurance coverage. The negatives include the fact that he is a smoker. He smokes 2 packs of cigarettes per day. He lives on the outskirts of town, so he's a little further away from healthcare. He is depressed at the moment. He has a depressed effect. He's older in age. His home is not handicap accessible, so it's going to require some construction to get that accessible for him. And the fact that he has some comorbidities that he's dealing with and his overall health status is not optimal at the moment. So those are all negatives for him.
There are multiple healthcare providers that will be a part of the team for Mr. Pearl. The primary care physician will be involved in the medication needs and any other medical changes for the patient, while the orthopedic surgeon will be in charge of the plan of care and making sure the residual limb is progressing as expected. The physical therapist will be the primary healthcare provider for rehab activities and education and trying to return the patient to the prior level of function. The psychologist is important in managing the mental issues that come with amputation, such as the stages of grief. The prosthetist will be very important in the rehab plan of care in order to find the proper prosthetic to fit our patient. The OT will be important for improving performance in ADLs and activities around the gas station. The respiratory therapist will be involved due to the history of smoking and diagnosis of COPD. The patient will likely require services of the respiratory therapist to ensure maintenance of adequate lung function. The social worker will be involved in discharge planning and making sure the patient's needs are being met by the healthcare team. A registered dietitian or nutritionist will be called considering the patient's medical history, and he will require frequent input from the RDN concerning his diet. The patient must improve diet to ensure he does not experience worsening health due to CAD or COPD. Recommendation to decrease consumption of meats and potatoes and increase consumption of fruits and vegetables. The pharmacist will track medications to ensure the patient experiences no adverse side effects due to drug interactions, and the patient may benefit from having medications mailed to him since the pharmacist may not be located close to his home. The nurse will be involved in the day-to-day care and updates for the patient, and the patient will be involved to meet all the healthcare needs and retain the ability to run the gas station independently. He will have to work hard and buy in on all aspects of the healthcare. He must change his diet, work hard in therapy, increase his activity level, stay on his medication schedule, and protect his unaffected limb to ensure he can function independently following amputation. For the examination for this patient, it will be important to look at their history to find their goals, personal and contextual factors to their recovery. Additionally, it will be important to do a vital signs screen to check for their blood pressure, heart rate, and respiratory rate, as they have cardiovascular and respiratory compromises. The residual limb should be checked for any compromises to the skin or the incision. The girth and shape of the residual limb should also be assessed. When doing range of motion, it is important to look bilaterally at both hip joints and knee joints to see if the patient will have any difficulty moving the joint through the range of motion. All of the joints in the lower extremity should be checked to make sure there are no restrictions when the patient is donning and doffing the prosthetic. Manual muscle testing should be done to check the strength and to assess the patient's potential need for assistance. As noted earlier, the residual limb should be checked for skin compromises. Additionally, the intact limb should be checked, especially in the foot, to check for any compromises to the skin there. Lastly, a neurological screen should be done to check the sensation of the residual and intact limbs to find any compromises in that system that may lead to further damage.
So the two subjective outcome measures that we were planning on using for Benny Pearl were the amputee mobility predictor and the hospital anxiety and depression scale. The amputee mobility predictor can be done with a prosthesis, where it's called the AMP Pro, or without a prosthesis, where it's called the AMP No Pro. It can be administered in 10 to 15 minutes or less, and it requires very little equipment to complete. It has been found to be correlated with a 6-minute walk test and comorbidities, and it has also been found to be a strong predictor of the distance that a patient will be able to walk with a prosthesis following an amputation. The AMP was designed to objectively assess the ability of a person to ambulate with a prosthesis following an amputation. Therefore, it is commonly used prior to fitting a patient with a prosthesis in order to predict the functional mobility of a patient after they are fit with the prosthesis. The AMP consists of 21 items where it's assessing transfers, balance, and mobility, and it converts the final score to a K level to better help you fit the patient with a prosthesis. Both the AMP Pro and the AMP No Pro were found to have high intra-rater and intra-rater reliabilities, and the intra-rater reliability was found to be about 0.99 for both, and the inter-rater reliability was found to be about 0.99 for both as well. It was also found to have a high test-retest intra-rater reliability. And for the AMP Pro, the ICC scores for the first trial were found to be 0.96, and for the second trial were found to be 0.99, which were both very high. The AMP No Pro ICC scores for the first trial were found to be 0.97 and 0.86 for the second trial, which are both also pretty high. So the second item outcome measure that we were going to look at was the hospital anxiety and depression scale. For this scale, the patient is asked to rate 7 statements for anxiety and 7 statements for depression. Each item is scaled from 0 to 3, and the final score, if it's between 0 and 7, is found to be normal. 8 to 10 is found to be borderline abnormal, and 11 to 21 is considered abnormal. For the anxiety questions, the specificity of 0.78 was found to be for this test, and sensitivity of 0.90 was found for this test as well. The depression portion had a specificity of 0.79 and a sensitivity of 0.83. This is an appropriate outcome measure because the patient came in with a depressed affect.
The 2-minute walk test correlates with both the 6 and 12-minute walk tests, however, has been validated in the lower extremity amputations population. Because of our patient's previous limitations and activity level, it will be easier for him to perform the 2-minute walk test instead of the 6-minute walk test. The 2-minute walk test is predictive of the 6-minute walk test, and in the study that examined subjects with K levels 1 through 4, the 2-minute walk test was found to be statistically significant for its correlation to the 6-minute walk test for all K levels examined. A 2-minute walk test distance of greater than 113 meters is required for patients to be likely to walk greater than 300 meters in the 6-minute walk test, and therefore demonstrate community ambulation potential. The L test examines transfers and turns in order to assess the functional mobility of the patient. It can also be used to assess the patient's basic mobility with a prosthetic. This test is a modified version of the tug and incorporates 2 transfers and 2 turns for a total walking distance of 200 meters in the shape of an L. This test has been validated in patients with lower extremity amputations, and norms have been established for this population and have high concurrent validity with tests such as the tug, the 6-minute, and the 2-minute walk tests. The timed up and go is another good test to assess the patient's functional mobility and ambulatory status. The test has a high reliability related to the risk of falls and ability to ambulate in the household or community. It has been validated in the lower extremity amputations population and has established norms in this population. The cutoff score for the tug for the lower extremity amputation population is 19 seconds. The 5-meter gait speed or timed 10-meter walk test has not been validated in the lower extremity amputations population, and therefore there are no norms for this group. However, this test can be used to assess gait speed, which can be used to assess fall risk and ambulatory status in these patients. The patient was given a K level of 2 as he still has the ability to ambulate around the house and potentially the community. A K level of 1 would represent the patient only has the ability to do transfers from the chair to the toilet or to the bed. However, our patient does have the ability to do limited community or household ambulation. Medicare defines a K level of 2 as having the ability or potential for ambulation with the ability to traverse low-level environmental barriers such as curbs, stairs, or uneven surfaces, typically that of a limited community ambulator. Because of his desire to return to work, it will be important to work with Mr. Pearl on traversing these low-level environmental barriers and to train him in limited community ambulation. The body structure function impairments for Mr. Pearl include the right transtibular amputation, ABI of unaffected leg of 0.8, 31.6 BMI, reduced oxygen saturation in his tissues, balance impairments, confused and depressed mood, decreased right hip and knee strength and range of motion due to his amputation, and pain from his surgery and possibly from phantom limb, as well as lower limb flexibility and contractures. Mr. Pearl's activity restrictions include unable to transfer bed to chair or wheelchair, unable to transfer to toilet, tub, or car, currently unable to ambulate, unable to doff or don prosthesis. His participation restrictions include unable to perform work-related tasks.
The prognosis for Mr. Pearl to achieve his physical therapy goals is good. Due to recent transtibial amputation, Mr. Pearl has some psychosocial issues in addition to various physical and functional deficits that can be improved over time with physical therapy. The patient has been in isolation in an inpatient rehab facility and is dealing with depression, confusion, and grief over the loss of limb and the change in lifestyle that accompanies it. Educating the patient on the realistic future opportunities for return to work and helping to alter ways in which he can complete activities of daily living in the most independent manner possible will help the patient progress with acceptance of current state. Negative contextual factors possibly affecting rehabilitation prognosis include smoking history of 2 packs per day. He lives in a small house which will make wheelchair use difficult and will require extensive construction to adapt to current functional needs. He has COPD and CAD and has a BMI of 31.6. Due to the culmination of these factors, the patient will need to be educated on the importance of smoking cessation, diet, and care for residual limb, ensuring that blood flow to limb is adequate. 2 positive prognostic factors: our patient is married and his wife can be a caretaker for him as she is a registered nurse. So she will help with dealing with needs at home and adherence to home exercise program. Secondly, patient is very motivated to return to work and gain his functional independence back. So through skilled physical therapy intervention, it is expected that the patient will make a full recovery to functional independence with his new prosthesis.
Important education for Mr. Pearl will include realistic goals for work, modifications of daily activities, smoking cessation, especially due to his already impaired ABI on his other limb, as that will increase the risk that he may have to have an amputation on the other limb. A healthy diet for the healing process, and residual limb care, including limb wrapping, shrink reuse, donning and doffing the prosthetic. As mentioned earlier, the patient will be at K level of 2. This K level will provide limitations on what we can choose from. However, there are still things that fall within this category. The patient will need a cushioned liner instead of a locking liner because a locking liner requires dexterity that the patient will likely not have. Cushioned liners with sleeve suspensions make it easier for the patient to put on. The foot component of this prosthetic will be a flexible keel foot, specifically the Endolite senior foot. The Endolite foot fits within the K2 limitations. The foot is not an energy storing or return foot, however it is very light and will not create any added stress on the hip and knee joints. This foot will also provide some motion at the toe for walking, but again it fits within these K2 qualifications. Lastly, the prosthetic will be a patellar tendon bearing socket, as that is the preferred method to relieve any pressure on the bony prominences at the knee. In the short term, our goals focus on independence with wrapping the residual limb, independence in transferring with the use of a transfer board, independent wheelchair mobility, assistance needed in donning and doffing the prosthesis, spending 6 hours a day in the prosthesis, as well as ambulating with an assistive device. In the long term, we will focus more on walking with the prosthesis. We want the patient to be independent in donning and doffing the prosthesis, ambulating independent, as well as ambulating while carrying objects like he would for work-related activities, and ascending and descending stairs with minimal assistance.
Throughout the first 5 weeks, we will begin treating Benny with limb wrapping, as well as instructing him on how to perform the wrapping independently. Once his sutures have been removed, we will transition to the use of a shrinker instead. The purpose of these wrappings is to control the size and shape of the residual limb, as well as reducing post-operative edema, which can lead to pain and vascular compromise through compression of the small blood vessels of the limb. We'd like to shift to a rigid or semi-rigid dressing if it is tolerated, as these have been shown to offer decreases in healing time, edema, and time to prosthetic fitting. Proper positioning for Benny will also allow for better functional outcomes, particularly in reducing his list for limb contractures. The typical limb positions for a transtibial amputation such as Benny's are shown on the slide. It is important to ensure that Benny does not elevate the leg, which has been shown to only minimally reduce edema, but at a significant risk of developing a hip flexion contracture. Similarly, he must avoid placing a pillow under the knee due to the risk of developing a knee flexion contracture. Contracture-free recovery is important for the patient's balance and ambulation when using a prosthesis. Active range of motion, strengthening, and endurance within safe dimensions to reduce the difference between limbs will allow for a more quick return to gait and better outcomes with the prosthesis. Previous studies have found a good response in these parameters with residual limbs and noted the presence of fatigue and atrophy that tends to exist following a limb amputation as reasons to prioritize strengthening in these individuals. Some examples of appropriate exercises to include are shown on the slide above. We'll assess Benny's balance very early on. Given that he has a unilateral amputation, it is unlikely for him to have difficulty with seated balance, but it will be important to assess for any deficits. Improving his mobility and ability to transfer to and from a chair or bed is also important. Teaching him to lead with the unamputated leg will serve to protect his residual limb during the transfer, as well as allow him to feel more confident and safe in standing for the transfer. Gait and pre-gait training will involve teaching Benny to use crutches, as well as typical gait training for post-transtibial amputations such as the above-mentioned strengthening and endurance. Previous research has shown that the strength of the hip extensors and abductors, as well as the knee extensors, are all critical components of return to gait in a post-transtibial amputation patient. Crutches are both simple to use and provide the patient a great deal of independence in performing their activities of daily living. Additionally, they allow him to have a less sedentary lifestyle, which would be a risk factor for reduced overall outcomes. To control for his pain, we will also be incorporating neuromuscular electrical stimulation with our strengthening program at 15 to 20 minutes per day, 5 days a week, which is something that Benny could very easily do at home that would not only decrease his pain, but also improve his function. We may also incorporate manual therapy to reduce his pain. Although there is limited evidence to support its use in amputee patients, it is warranted to try this method if his pain is not resolved throughout our other management. We also take advantage of techniques to desensitize the limb, including massage, soft tissue work, scar mobilization, and gentle tapping. Education for Benny will primarily involve protecting the residual limb during movement until it is fully healed, as well as the above-listed positioning concerns. Additionally, we will want to preemptively educate Benny on the possibility of phantom limb pain, skincare for the residual limb, and making him aware of his increased risk of falls and the risk that he has for his remaining limb due to his vascular condition.
Alright, so now we're into interventions phase 2, and this is going to be occurring from week 6 to 10. So once the patient is in this phase of rehab, they'll be fit with a temporary prosthesis. This first prosthesis will last anywhere between 3 to 6 months. And this is just due to the fact that there's still shrinkage occurring, mainly due to the pressure from the patient's body weight as it is applied to the residual limb on the prosthetic socket. So that's going to cause that residual limb to continue to shrink. So after about these 3 to 6 months, he'll be fit with a new, more permanent prosthesis. It's important to get used to the one that he has. So the patient's already begun pre-gait training in phase 1, and he will continue that as well as work on some direct gait training with his new prosthesis. So that's really going to be super important for him. Mr. Pearl also told us that he's very eager to get back to work as he feels that he needs to. This is likely due to needing to maintain his store and help contribute financially for his family. As he's eager, though, he may think that he will end up moving super quickly through therapy and be able to immediately get back to work after getting his prosthesis. But it's important to, kind of educate him a little further, a little deeper about all this so we can go through all our interventions, particularly gait training, to make sure that he's moving in a really safe and efficient way. And those are our main goals. So education becomes really important and really critical during this part, and he needs to understand that it can take anywhere between 3 to 9 months for a patient to regain their strength and flexibility in their leg. So some of our main interventions at this point are going to be, he has his new prosthetic, so it's going to be donning and doffing the prosthesis so he's comfortable with it. Balance, as you'll see a little bit further on the next slide. Cardiovascular fitness, so there's a study, the one I have noted as air-dyne ergometer training, that was by Patetti et al., and it showed that there was an increase of 25% in maximum capacity for exercise when training on the air-dyne ergometer, and significantly lower heart rate and oxygen consumption during submax walking on a treadmill on various incline grades after they went through a period of riding on the ergometer at about 80% or 60% in that range of max heart rate. And so they built it up over time, and these improvements were particularly important for Mr. Pearl, who has a history of cardiorespiratory issues. So we really want to work on his cardiovascular fitness and endurance and promote heart and overall health, as well as to get him to exercise a little bit more in order to hopefully aid in some weight loss and get down to a healthier BMI, because unfortunately he is a little heavier. We also were talking about the flexibility. So the Boker, in his book of the Atlas of Limb Prosthetics, talks about contractures, and the most common in a transtibial amputation is a knee flexion contracture. So you just want to be aware of that and any other possible contracture formations. Education is really important. You want to have the patient follow the wearing schedule set forth by their prosthetist. We really want to focus on safety and just manage his expectations. Alright, so continuing on with the interventions for phase 2, we're going to be working on some strengthening and gait training. So gait training includes a flat surface as well as using stairs. When you're teaching them how to go up and down stairs, you want them to go up with their unaffected limb and down with their prosthetic limb. So initially, it may be beneficial to use body weight supported treadmill training, and this can help in several different ways. So Mr. Pearl can begin getting used to weight bearing and balancing, as well as equal weight distribution between his prosthetic leg and his non-affected leg, as well as taking the fear of falling out of the equation by having that body weight support. So he's not really going to be as nervous. It should help kind of transition a little bit quicker. When comfortable, the patient can increase the speed that they're walking on the treadmill. And a study by Hunter et al. Showed that with 40% of the body weight supported, there were significantly lower ratings for RPE, heart rate, and oxygen expenditure. And this was once they reached a speed of 3 miles an hour or 1.34 meters a second. So it said the main effects in the early stages of training would be the confidence that the patient receives from having the fear of falling taken out, as well as boosting their balance and getting more used to weight shifting. But once you get up to that higher speed, you actually see some more physiological improvements that could be really beneficial as we're getting Mr. Pearl trained again. So another study that we saw examined impairment-oriented interventions immediately after receiving a patient's initial prosthesis. So they had a 10-day training program led by a physical therapist. And the protocol was broke down functional activities into parts. So for the impairment-oriented group, they had pre-gait training and standing, such as balance training, weight shifting in all planes, dynamic reaching, stepping up and down from a low step and single stepping. And this took about 50% of the time, and the other 50% of the time was corrective walking with verbal and tactile cues to promote a symmetric gait pattern, and they could use an assistive device as identified by the physical therapist if needed. And so the group that this was compared to spent about 90% of the time doing the corrective walking and only 10% doing pre-gait activities. Both groups ended up seeing significant improvements in outcome measures such as the Berg Balance Scale, velocity of walking, and the AMP-PRO. However, the impairment-oriented group saw significant improvements also in walking cadence, double limb support time, and the percentage of gait cycle in stance and swing phases when compared to the task-oriented group. So that means that pre-gait activity should still be incorporated in this phase of physical therapy, particularly with balance, weight shifting, reaching, and using steps. So we found that's really important. We want to include that and kind of split up that time about 50%, 50% as they did in this study. So we also want to make sure we're addressing typical gait deviations that are common after someone has a transtibial amputation. So some of the typical gait deviations to monitor for are absent knee flexion or knee instability, and this would be likely due to quadriceps weakness. Excess knee flexion, which could be due to knee flexion contractures or the foot position too posterior to the socket on steps. We could have knee hyperextension, which is the positioning of the plantar flexion on the foot, as well as things directly regarding prosthetic fitting, such as whipping, which could be the knee internally or externally rotated, or suspension issues, or pistoning, which can be a variety of things such as inadequate suspension, a large socket, or not enough socks fitting that socket. And again, so like I said, quadriceps weakness can be one of the main things that could lead to different things, such as absent knee flexion or knee instability. So that's one of the areas we really want to focus on with strengthening.
The multidisciplinary discharge plan for the patient will require him to meet several different criteria. First, he must meet the criteria for a limited community ambulator and that he can walk at least 300 feet with only 1 to 2 rest breaks. He must have little to no fall risk and must be independent in transfers from level and non-level surfaces and be able to independently sit to stand and stand to sit. The patient will also demonstrate the ability to walk at least 150 feet without stopping, making him a household ambulator. The residual limb will be fully healed, which will require input from the orthopedic surgeon and the medical doctor, and the prosthetic will be properly fit for the patient, which will require input from the prosthetist. The ability to don and doff the prosthetic independently will also be required of the patient, which will require input from the prosthetist, the physical therapist, and the occupational therapist. Referrals will be given for the patient to go to respiratory therapy for his COPD, a dietitian for better nutrition and weight loss, and a psychologist for smoking cessation and any other of the stages of grief the patient might currently be in.